The pain is localized over the lateral epicondyle, which is described as point tenderness right in this area. And that's where all the pain comes from, and that's where the injection usually goes to treat it. It's tender to touch it there. There's full range of motion of the elbow, no effusion, no swelling, very little radiation of the pain. But the pain is quite intense, particularly if you try to grab something when the elbow is extended, like grabbing a book off of a shelf. That'll hurt and you can't do it and cause you to have pain. Otherwise, it seems to be okay, except when you stress in certain ways to put pressure on the extension of the elbow, which is the insertion of these muscles are right over the lateral epicondyle. Point tender right there. The treatment can be some non-steroidals, but that usually doesn't help very much. The definitive or perfect treatment is a local injection of cortisone. You use a long-acting Depomedrol, 40 to 60 milligrams with a couple of ml of lidocaine. You have the patient localize the period of point tenderness, prep the area, inject with a 25 gauge needle about 2 or 3 cc's of fluid, and it'll diffuse over the area. You should get immediate relief of pain because the area that's inflamed is numbed by the lidocaine. So that will prove that you're in the right spot, because now the pain will be normal, and when the lidocaine wears off, it'll come back. It takes 2 to 4 days for it to get better. Sometimes there's a post-injection flare. For the first 12 to 24 hours, it hurts a little bit more because of the steroids. With that, you can take some Motrin or Advil, and that usually takes care of it. After the injection, you usually don't need any additional medications. The condition is often recurrent and will come back oftentimes in a couple of years. Some people can put a brace around the elbow, which takes away the insertion, really, of the extensor muscles and changes it so you don't have a continual tearing or pressing on there. That's why I see people playing tennis wearing these elbow constrictions that really change the origin of the muscle. As a caveat for the injection, if you use a 25 gauge needle and about 3 mLs of fluid, a combination of the Depomedrol and the lidocaine, the patient rarely feels it. What you do is you find the area of maximum tenderness, and you go down and hit the bone with a needle, because that's the insertion of the muscle, and then you pull back a couple of millimeters, and it should inject very easily and balloon up the tissue. You don't want to do the periosteum, but if you hit the bone, that means you're right on the area where the muscle insertion occurs. Although NSAIDs and the steroid injection helps the initial acute process, the way to handle this is to get physical therapy to condition the area so it doesn't happen again. So if it happens more than once, the patient should be referred to physical therapy to go undergo exercises that can keep this from coming back. Right there.
Okay, good. And then bend your wrist back. Push against me.
That hurts.
And then squeeze my hand like you're shaking my hand.
Yeah, that hurts too.
Great. Yeah, that's a tough question. I'm sure it depends on the area that you're working in. In Philadelphia,
I work in the Mercy Hospital, and there's very little follow-up and no primary care, so I haven't been injecting them for years.
yeah.
But,
Then I think that's fine.
but they oftentimes, never get any follow-up.
But what I'm concerned about is not getting follow-up. I'm concerned with too much follow-up. Getting a shot from you, and 2 days later showing up in an orthopedist's office, and then 2 days later going back to the ER. That's what I worry about. But I think for people who have less follow-up, I think that's the better person. Just Just relax your elbow for a second. Down 3. 1, 2, 3. Go. Go in. This is the medicine to numb and just moving it around the area. So once the medicine's in, I'm right on the bone here. I give it 5 seconds to work. And then I start to massage the muscle. And that's it. So this is, if this is the bone on your elbow, and this is the muscle coming down your arm, tennis elbow is where you get a little degenerative tendon at the tendon insertion on the bone. And this is an overuse injury, so you'll get this, the body will heal it, you'll get it again, the body heals it, get it again, body heals it. And then over time, the degenerative area will get a little bit bigger, and that's when you end up in the doctor's office, because now the pain is much worse. But this is not tendinitis. This is not just an inflammation of the tendon. This is actually a degenerative tendon, tendinosis. And so the tendinosis, the degenerative tendon, doesn't just go away with a little Advil or Motrin, whereas tendinitis would. So the way that you have to get this to go away is you have to basically wake up the body and stimulate the body to heal itself. You have to tell the body it's still injured, you're not done with your job, get back to work and fix the tendon. And the way you do that is by stimulating a healing response, which is basically a no pain, no gain type situation. So you want to irritate the tissue to stimulate it to heal. And so we do that with many different things. One is massage, but just manual massage, deep massage, not like a cutesy nice massage, but right into the spot that hurts, rub it hard, and that can stimulate some bruising, and which wakes up the body and heals with good healthy tendon. And there's stretches and exercises. Those are for the muscles that attach. So if you stretch those muscles and you irritate the attachment point, then that will eventually stimulate a healing response. You know, when you lift weights and pump iron, people always talk about micro tears. You get micro tears in the muscle. It's the same idea. By doing some exercises, you get micro tears. But you don't want to do 500 repetitions, because then you're just going to do the over activity all over again. So you want to do maybe 20 repetitions and then quit. Just a little exercise. And then stretches as well. And we'll give you a handout with some stretches, but it's a lot of bending the wrist down, bending the wrist up, and rotating your wrist. Just very simple stretches to stretch the muscle. And then there's a tennis elbow brace that people wear, where you put a brace around your arm right about there. I'm sure you've seen people with those.
Changes the insertion.
Exactly, changes the insertion, spreads the force out, basically resting that muscle so you don't get the same overuse. But you don't need to wear the brace all the time. You wear it with your activity. If you know what activity is causing it, whatever sport or weightlifting or typing on a computer, whatever it may be, that's when you want to wear the brace, not necessarily to bed. And then the last, which I think is very helpful, is the injection. And so the injection, the key behind the injection is not so much the medicine, because there are lots of different things that people are injecting into tennis elbow now. There's prolotherapy, PRP, cortisone. Some people just use numbing medicine, but the real magic behind the injection is actually the needle. When the needle goes in, after we inject the medicine that numbs the area, we move the needle around kind of aggressively, and you move the needle around, and it actually is the ultimate massage to the area. It'll cause some bruising, it'll cause some pain afterwards, but ultimately that really stimulates a healing response. And so I tend to encourage the injection on people.